Are we ready? Okay. Good afternoon. Dear audience and participants, we have the pleasure to start the awards or abstract discussion. And we will start by Professor Rida Tabashi from the NCI. And his presentation in 10 minutes, I wish every participant and speaker will stick to the 10 minutes. It's a very interesting title, by the way. Irreversible electroporation, which is very mysterious. For perihilar hepatocellular carcinoma, it's an initial experience and pilot study. Go ahead and stick please to the 10 minutes.
If you can.
The Chairman, it makes sense too. Now, my study is the reversal of electroporation of very high hepatocellular carcinoma, initial experience. Local electrotherapy therapies are being used increasingly to treat primary and metastatic hepatic tumors, with the most common techniques is RF and microwave. There is a high recurrence rate with these ablative techniques ranging from 4 to 34% in hepatocellular carcinoma. Proximity to major portal veins has been associated with suboptimal ablation and high recurrence rate. Also, complications can be caused by thermal damage to the major bile ducts and blood vessels. The reversible electroporation is a new ablative technique and has the advantages of non-thermal action preventing damage to major portal veins and bile ducts. This initial experience evaluates the safety and efficacy of IRE to ablate the very high HCC. 10 patients with 10 very high HCC were recruited in our study. The patient's age ranged from 55 to 62 years. Patients were referred from the multidisciplinary team. IRE was decided that the thermal ablation was not indicated due to the tumor applications. All 10 lesions were in the perihilar regions. Perihilar region ranged from 3.5 to 5 centimeter with range 4.5 centimeter. All lesions are treated percutaneously. This is the non-knife system from Angiodynamics. It has a generator and ECG synchronization device and electrodes. The blue one is the active electrode and the white one is activating electrodes. Physical background electroporation is a way to increase cell membrane permeability by subjecting it to an alternate electric current. As you see, poration of the cell wall and destruction of these cells by apoptosis. This immune-mediated cell death allows cellular clearance to creates minimal tissue distortions after ablation. And finally, the cells phagocytosed. When we apply electrodes, it should be 2 centimeter, maximum 2.5 centimeter between each electrodes. Rapid series of short, high voltage DC currents applied between these electrodes. Around every 2 electrodes is an area of irreversible electroporation. Outside is an area of reversible electroporations. This reversible electroporation area enhances the chemotherapy effect in the tumor, on the tumor cells. The clinical advantage of IRE is the non-thermal technology, no incomplete treatment around vessels. As you see, the explanted liver, after this application of 3 electrodes around the vessel is still intact, with a clear cut between the normal liver and the ablated area. Here in experimental animal study, IRE around the carotid artery, you see that just after electroporation, muscle cells reduced in number but regenerate after a few weeks. During the IRE, you see that the vessel is not impacted, is not obliterated, is not thrombosed. Even after explantation of the biopsy, the vessel is still intact with normal. Also, bile ducts cannot affected by the IRE. MRCD before, just after 2 days, then regenerate of the wall and renormalization. The issue in IRE is relaxation absent general anesthesia, and non-depolarizing muscle relaxations. It should be also monitoring of the ECG and the arrhythmia of the heart is important during the procedure. The treatment planning is as input issue. They should be end to end and should be parallel to each other. No conversion, no diversion of the electrode. Should be parallel end to end to act well. If the needle is too nearby, the lesion is small, is far, you see that areas can be missed during ablation. If we stick to 2 centimeters apart, the lesion is well affected. Male patients 6 years old presented by large perihilar. You see the enhancing lesion around the hilum, arterial phase 2 pictures, 2 images. By ultrasound, it is addition to the hilum of the liver and the gallbladder. The middle image is 2 electrodes in the upper part of the lesion. In the lower one, the lower picture is 2 another electrodes in the lower part of the lesion. You see that it is just abutting the gallbladder, just abutting the hilum of the liver. This 1 month follow-up, you see no enhancement at the area of the lesion in the arterial and the portal phase. 4 months later, you see that it looks like normal liver, no enhancement, and also the tumor is decreasing in size. Another case with patient 53 years old, you see that the 4B segment adjusts anterior to the hilum of the liver, in the arterial, portal, and the late. Also, by ultrasound, the upper picture, application of 2 electrodes in the upper part, application of 2 electrodes in the lower part, and here the 4 electrodes in shortcut. The arrow is indicating the 4 electrodes. You see that the distance is mostly equal between each others. 1 month later, you see nothing. You see nothing in the area of the venous lesion. Only you see that an air liquid is present, just anterior to the liver hilum. It is the air in the duodenal cap. It is not the air in the lesion. It is air in the duodenal cap. So no injury in the duodenum, no injury to the hilum of the liver. 4 months later, you see the same picture. The lesion. Complete ablation in 9 patients out of the 10. The residual tumor was present in the first case I did. No major complications. Only 1 patient developed mild right loop intrahepatic dilatation and disappeared after the second follow-up. Also, one patient developed portal vein thrombosis, mostly due to more nearby to the portal vein, also disappeared after the second follow-up. Follow-up was relatively short, ranged from 8 to 18 months. No tumor recurrence along this short follow-up. IB appears to be safe and effective ablation technique for the treatment of perihilar HSC. However, larger studies with longer follow-up are required to confirm these results. Thank you.
Professor Reda, you please, what are the contraindications to this technique?
Contraindications?
Yes.
First, patient not fit for anesthesia. First.
Yes.
Like arrhythmias, epilepsy, also metallic device within the nearby, like metallic common bile duct stent. Coronary stent, artificial metallic features. Also coagulation profile, like any other ablation.
Do you think, Doctor, that you can, because I have seen that you concentrated on very highlight lesions, do you think that this further can be extended to different segments in the liver, or there is a technical difficulty in the application of the flow.
Expensive technique. It is expensive technique. So we consider it in the very hierarchy because RF has a complication here. In this region of the lever, there's complication after RF or microwave.
So it is like an alternative to
frequency. Also very higher regions, an anatomical issue that very higher region of the liver has no specific arterial supply.
Yes.
No major artery for it. May take from the left hepatic artery, may take from the right. Usually we see it before this era of treatment, we do chemoembolization for these lesions. We see very tiny, this is about this lesion. So, to decide or to do chemoembolization, we do non-selective chemoembolization. Non-selective. By mean that we inject chemotherapy all over the liver. And the patient has a high risk to liver shutdown, liver failure.
Therefore, this is a selective.
Few patients from our study done taste for 3 to 4 times with no response.
Actually, I have to congratulate you. This is a very interesting maneuver. And
Actually, I go to the abstract to all the abstract, and I was astonished with this abstract because I found it very attractive. I have like 1,000 questions, but I will ask you 2 questions only. First, you know that when you disrupt the liver cells, the issue of cirrhosis is by the immune system attacking the debris of the liver cells. So this is the same. Do you find any cirrhotic changes, or this is the follow-up is short, but do you think that it might be similar to the action of the immune system on the disrupted liver cells? It is. You can't tell. You can't tell. You have to take time.
We make the cell to do apoptosis for itself. Then the phagocytic cells come to
clean the.
Yes.
You make the cell rupture.
Yes.
And the ruptured cell is attacked by phagocytic cells. This is what happened in plasmacytoma. Yes. This is the same.
There is the difference between electroporation and RF. RF is a thermal agent.
I know. This is why you attack this very high dose, because it is the vessel, so it is not applicable for radio frequency. Yes. It is applicable for this. The second, why is the limitation to 5 centimeter? Can you increase the size? Because you are applying the electrode or whatever you apply 2 centimeter apart. Yes. So if it is 8 centimeter, you can apply 4 electrodes or something. Theoretically, what is the difference?
8 is too big. But actually, the maximum number of needles can I put in the patient is by measurement we can apply 4.7 multiplied by 6.3 maximum lesion. Lesions like this, we will take a more time because the technique is lengthy, it takes a long time.
How long it takes?
Maybe 2 or 3 hours.
Okay.
No. But you have that there is an area of irreversible occlusion in the middle and the area of reversible reversal and the version. This is enhance the chemotherapy if I apply chemotherapy from outside. So this is my question: is that if I can do chemotherapy with this, so I can treat a bigger. Yes, this is why I asked.
Yes. Also, this idea, this combined method is better for both metastatic liver disease and pancreatic cancer.
I will do an article with you in this combined together.
Most of these patients are treated previously on space.
2 patients.
Yeah.
Or 2 patients.
But you prefer to start at first by the technique in addition to this?
Nowadays, I would decide nanolife from
In addition to this, yeah.
taste before this machine installed in our institute.
Thank you, Professor. Thank you.
واخر حاجه بقى تتكلم كام مجال عشان بس ابعت لك عينين
needles about 25,000 needles.
But do you believe that 3 hours of anesthesia for HCC is something as regards the liver function and 3 hours of anesthesia.
They may have decompensated liver.
Yeah.
This is by exclusion, not to include decompensated liver.
Okay. Thank you, Professor Rida. I think it is time now to introduce one of my active member of my department, Associate Professor Rasha Hangak. Professor Rasha Hangak will introduce the title Rituximab-induced hepatitis C virus reactivation in HCV-positive patient with diffuse large B-cell lymphoma.
Our study is entitled Rituximab-induced hepatitis C virus reactivation in HCV-positive patients with diffuse large cell lymphoma. Worldwide, an estimated 130 to 210 million people have hepatitis C virus infection, and the highest prevalence of HCV has been reported in Egypt with an adult prevalence of 15% for anti-HCV antibody, and this prevalence of HCV-infected individual with non-Hodgkin lymphoma published series varied from 0.5% to 25%. In the pre-rituximab era, patients reported that HCV-positive diffuse large cell lymphoma patients had poorer overall survival, but not event-free survival compared with HCV-negative patients. But the clinical outcome and the hepatic toxicity occurrence of diffuse large cell lymphoma patients with HCV infection in the rituximab era remains controversial. In this retrospective study, we compare the clinical features of diffuse large cell lymphoma patients with or without HCV infection, and we also compare the treatment outcome and HCV reactivation rate of patients who received shock or partial regimens. In our study, we included sequential patients who were 18 years of age or older with pathological confirmed diffuse large cell lymphoma diagnosed during the last decade at our department, medical oncology department, faculty of medicine, Zagazig University, in collaboration with a private hospital in Cairo. All eligible patients were included either received shock or are shock according to availability of the rituximab. We included patients with positive hepatitis B surface antigen or core antibody, patients with positive HIV, patients with primary CNS lymphoma, patients with impaired liver function reserve who had defined as child classification 7 or higher. Liver function test and neurological studies, data on HCV infection status and diagnosis of lymphoma were collected whenever available, either HCV serology, quantitative or qualitative HCV RNA. Patients with HCV infection were reviewed to outline the different patterns of HCV infection as we defined HCV RNA PCR detection level to categories. First one, undetected to be less than 25 international units per million. Low viremia is to be less than 100,000 international units per million. Moderate viremia from 100,000 to 1 million. And high viremia if more than 1 million international units per million. After that, evaluation of the viral reactivation or the enzyme failure. First, the liver function test was screened carefully before and during the treatment, as well as during the follow-up period. The definition and the grading of hepatotoxicity were based on the National Cancer Institute common toxicity criteria. Enzyme failure or the acute exacerbation of chronic HCV virus infection was defined as a 3-fold or greater increase in the serum ALT level above the upper limit of normal. In absence of use of hepatotoxic drugs, other than chemotherapy or recent blood transfusion or other systemic infection besides HCV virus. HCV reactivation, the other name is viral failure, was defined as increase in the HCV virus viral load at least 1 log international unit per million. As in chronic virus C, we have fluctuation of the level of the RNA from 0.5 to 1 log. So, 1 log or more is considered as reactivation. So, the reactivation is increased 1 log or more over the baseline after following chemotherapy or immunosuppressive therapy, the appearance of the HCV virus RNA, or sudden increase in the HCV RNA level. Our results reveal that according to the baseline characteristics of 132 patients, we have 35 patients with positive HCV virus and 97 patients with HCV negative. Comparing the characteristics, we have equal baseline characteristics between both groups, except for B symptoms was significantly more in the HCV virus group, and also presence of splenic involvement was more in the HCV virus group. Other characteristics was equal, especially the treatment regimen distribution between both groups. According to survival outcome, the median follow-up time in the HCV virus positive group was 22 months versus 31 in the negative group. Overall survival rates, either 1, 3, or 5 years, were also equal between both groups and also for disease-free survival. So the HCV virus positivity didn't affect either the overall or disease-free survival. And these data are here, clear here in both curves. This is the overall survival curve as we see. The p-value is 0.9, and here for the disease-free curve, it is 0.7. univariate analysis, which was a significant one, and we detected in the multivariate analysis that the prognostic factor which can affect survival for the disease-free survival, extranodal performance status, hepatic involvement, or splenic involvement criteria didn't affect except for this splenic involvement. Also, it is a only significant factor in disease-free, but for the overall survival, all was significant. Extranodal more than one, high performance status, presence of hepatic involvement, and the presence of splenic involvement. Regarding the hepatic toxicity and delayed chemotherapy, out of the 132 patients, 64 patients received the R-SHOP and 68 patients received the SHOP-REF. Among the HCV infected patients, the incidence of hepatitis failure was 40%. This is the enzyme failure. 14 out of 35 patients versus 9.3%, which was 9 of the 97 negative patients. And this was highly significant. So, HCV positive patients showed a relative risk of 4.3 to 1 versus HCV negative patients for developing liver dysfunction. And this also was highly significant. Regarding the HCV viral load, out of the 35 HCV positive patients, 14 patients, which represents 40%, received R-SHOP, and only 21 patients, 60% received SHOP. HCV reactivation occurred in 34.2, 11 patients out of the 35 positive patients without any relation to treatment regimen. So the distribution among these virus reactivation 7 for R-SHOP and 5 for the SHOP, and p-value was not significant. So no hepatic toxicity and also no hepatic toxicity related disease had been reported. Regarding delayed chemotherapy, treatment delay occurred in 23 patients who had enzyme failure, but only 4 HCV positive patients of those who had R-SHOP discontinued owing to hepatic toxicity. At the third, fourth, and sixth cycle compared to none of these patients who received SHOP regimen, which was not significant or marginally significant. So in conclusion, our study provides evidence that HCV infection didn't compromise the progression-free or overall survival for diffuse large-cell lymphoma patients. The incidence of hepatotoxicity was higher in HCV positive patients, and frequent monitoring might be required. And HCV reactivation had no relation to the type of treatment. And thank you.
ليه ما كتبناش يعني ارشف الكومبينيشن التوكسيمات بلس كيموثيرابي الاكتيفيشن هيحصل يعني ليه التوكسيمات بتدوس هيباتايتس يعني انت مش بتدي يا مريض
لا chemotherapy was assessed before for hepatic toxicity before. This is a new era. Toximab has a history of hepatitis B virus infection. So can this be translated to HCV virus?
طب انت في الاخر اخر دول سايب قلتي ديسكونتينيوشن تريتمنت في الفور بيشنتس الاشهر صح؟
انت اشهر جروبيس.
طب يعني كان مثلا كان مثال بعد فتره من التريتمنت البيشنت ما حصلوش مثلا الليفر انزايم ريتيرن تو نورمال نجرب معاهم ماسك ممكن ياخد سنجل روتوكسيماب بس ونشوف الليفر انزايم بعدها فيها ايه؟
هو fortunately those patients was MTR and one of them was in stage 1. And it was no need to continue chemotherapy because toxicity was for grade 4.
يعني كان داخل كومبليت ريشن فاميلي في كونتينيوشن
في بعض discontinued لان هو grade 4 ما نقدرش نرجع تاني.
طب المجرد الليفر انزايم تو نورمال ليفل and how high time قد ايه to normal يعني في these patients الميديان تنفع في التايم 1 week 2 weeks
هي from 2 to 4 weeks. هي في بس دول كلهم دير يعني median time to recover
some certain patients يعني
not needed.
and the rest انت عندك عملنا
Not to stop for a while the intensive and you, as you know in the guidelines we follow the enzymes either the viral code increase or not we at the end finally follow the AAT.
الفولو اب كليفر انزيم ممكن ولا كنا بنعمل الفيرينيا فولو ابليكيشن اللوب بتاع الفيرينيا.
This is a retrospective study, so we follow what we have been done. But in the guidelines, we should do the enzymes every 1 to 2 weeks and the viral load every 1 month. And we reduce this duration to every 2 weeks if there is enzyme failure or increase the viral load by PCR. We do it every 2 weeks.
Any other questions in the audience? شكرا.
Next speaker, Dr. Tamer Sabri. He will present endoscopic mucosal resection for high-grade dysplasia and intramucosal carcinoma in parenchymous.
Thank you, Mr. Chairman, and many thanks for your attending my presentation today, which is about endoscopic mucosal resection for high-grade dysplasia and the intramucosal carcinoma in parenchymous. As we know, parenchymous is a complication of long-standing urine, resulting in replacement of the normal squamous lining of the distal esophagus by columnar epithelium containing specialized intestinal metaplasia. It must be there's endoscopic surveillance which is recommended for patients with parenchymous in the hope for detecting dysplasia before it progresses to the adenocarcinoma. This surgery was traditionally has been recommended for patients found to have high-grade dysplasia or early cancer. Endoscopic therapy, which is the new era, has been proven to be safe, effective, and less invasive alternative to surgery for treating such patients. Endoscopic resection is an endoscopic approach in which the neoplastic epithelium is excised, allowing it a safe and effective definitive histologic diagnosis while also potentially being cured. Endoscopic resection does not impair subsequent ablative therapy like photodynamic therapy, argon plasma coagulation, or radiofrequency ablation for treatment of the larger areas of the residual parenchymous. Ablative therapy alone provides no specimen for histopathologic evaluation, and this compares endoscopic mucosal resection with other photo or ablative therapy, which is being the better to use endoscopic mucosal resection. Endoscopic resection is a cornerstone for endoscopic management, and ablative techniques are mainly used as an adjuvant to it. Evaluation for eligibility. Firstly, histopathologic evaluation. The second, the endoscopic workup. And the third, staging of the lesion. What is about histopathologic evaluation? Esophageal neoplasia is usually classified according to the Vienna classification, which is upon to the histopathologic evaluation of endoscopically acquired biopsies into many categories. Category 1, where is no dysplasia. Category 2, indefinite for dysplasia. Category 3, low-grade dysplasia, while category 4 high-grade intraepithelial neoplasia may be high-grade adenoma or dysplasia, non-invasive carcinoma, or suspicious of invasive carcinoma. And lastly, category 5 invasive epithelial neoplasia, intramucosal carcinoma, and submucosal carcinoma or PIA. There must be noted that histopathological study must be revised by another expert pathologist to confirm the diagnosis of high-grade dysplasia before endoscopic mucosal resection. Endoscopic evaluation. Patient diagnosed with high-grade dysplasia or pelvic cancer in the parasophagus should undergo an endoscopic workup in a cancer with expertise in evaluating such patients. Early neoplastic lesions in parasophagus are often difficult to detect with standard video endoscopy. A number of techniques have been proposed to increase the accuracy of endoscopic imaging, such as chromendoscopy or magnification endoscopy and optical coherence tomography, and etc. There is 3 general rules such being followed in the endoscopic evaluation of patients being considered for endoscopic resection. Use the best endoscopy available. And the second, have a vigilant eye for detecting the mucosal abnormalities. And the third, use the systematic, meticulous approach. Endoscopic resection techniques, we have 4 techniques. The first is inject adrenaline with saline and cut. And the second, inject left and cut using the double channel endoscopy. And the third, inject suction and cut, like methods of esophageal paralysis. And the fourth, ligate and snare using snare cup. And here is an elimination for the lesion, as we see here. This is the lesion, not exceed the mucosa. And then we inject the submucosal fluid injection to elevate the lesion up, and this is the line to snare when excite the lesion. And here is photos explaining the lesion. In photo A, there is a lesion not appear well. This with chromoendoscopy, and this is the picture after chromoendoscopy. Inject saline. This is the picture after injection. This lifting and snaring, and this is the last after snaring. And there is another picture showing also high-grade dysplasia in the parasophagus, and another technique which is using a snare cup, and the picture it was after the 3 weeks after endoscopic resection, and we will see a complete healing of the mucosa. Acid suppression following endoscopic resection. Patients should be treated with adequate acid suppression to allow the endoscopic resection wounds to heal with a new squamous epithelium, and probably also to reduce the local scarring. Most centers treating patients with high-grade dysplasia treated with high-dose proton pump inhibitors using esomeprazole 40 mg twice daily. The wound generally heals in 3 to 6 weeks, depending on the size of the resected area. No studies have evaluated the mucosal regeneration pattern after endoscopic resection. Healing proceeds from proximal to distal with regeneration starting from the edges. Efficacy of the endoscopic mucosal resection. The available evidence suggested that endoscopic resection for these conditions has an initial success rate comparable to the surgical treatment, but with fewer complications. Rate of complete remission. ranging from 59 to 99%, and the higher degree of success are seen in low-risk lesions, which are defined as macroscopic type 1, protruded type, or type 2A, flat elevated type, 2B, flat type, and 2C, flat depressed type. A lesion diameter up to 2 centimeters that is limited to the mucosa and histologically well to moderate well-defined tumors. What about the recurrence? Multiple factors have been associated with the recurrence: larger lesion diameter and the long segment parotosophagus, removal of the lesion with piecemeal resection, failure to perform adjunctive ablative therapy زي الفوتوديناميك ثيرابي, argon plasma coagulation أو radiofrequency ablation, presence of multifocal neoplasia, the presence of residual dysplasia. The most cases, recurrence can be successfully also managed by endoscopy, either with endoscopic mucosal resection alone or with combination with photodynamic therapy or with radiofrequency ablation. What's about the complication? Firstly, the bleeding is about 0 to 46%, which can easily also managed by endoscopy. Perforation ranging from 1 to 5%, and structure have been reported in 2 to 88%, and we see there's a wide range in this complication. It requires, so we say endoscopic mucosal resection must require expert endoscopist and expert center to do this procedure. Summary and recommendations. Patients with high-grade dysplasia and intramucosal carcinoma prefer to do endoscopic mucosal resection rather than surgery and ablative therapy. Endoscopic resection is particularly useful in patients with nodular lesions. Endoscopic resection aids in histopathologic diagnosis since it permits assessment of depth of infiltration. Patients with high-grade dysplasia or early cancer should be referred to specialized centers. Patients treated with endoscopic resection require regular follow-up to detect recurrence lesion. In most studies, patients are followed every 3 months during the first year and annually therefore. The most common complication from endoscopic resection are bleeding and esophageal structure formation, both of which can generally be managed by endoscopy. And thank you very much.
What are the recurrence rate between endoscopic resection versus surgery?
I think the recurrence not be global. Recurrence with endoscopic mucosal resection according to the size of lesion size. When we choose the correct patient, and we choose the lesion not exceeds 2 centimeters and will be no wide area circumferential, I think recurrence not exceed more than 2%.
The maximum diameter of the segment, 2 centimeters. You have any data about Helicobacter pylori in this series?
Yeah, I think Helicobacter pylori is not related more or less to this procedure. If the patient suffers from Helicobacter pylori, we will not delay our procedure, as Helicobacter pylori is not more dangerous than high-grade dysplasia in this subject.
Thank you for this presentation. How can you judge the depth of invasion? How do you do endosonography first or what?
No, the parotosophagus, either short segment or high segment parotosophagus, will be easily localized by HT endoscopy, which is the new era in endoscopy nowadays. Either long segment or short segment, we can detect the parotosophagus. Now we can use chromoendoscopy using methylene blue or indigo violet with the spray catheter to this area. Any high-grade dysplasia will take another color for the other mucosa. So this
change of color.
In changing color, we will take biopsy. Sent to the pathologist, and he will confirm our suspicious for either high-grade dysplasia or low-grade dysplasia. So if the pathologist report come with high-grade dysplasia, we will revise the slide again with another expert pathologist to confirm the diagnosis. After that, we will use the endoscopic resection to detect the depth of the lesion. Endoscopy in this situation will be diagnostic and curative in the same time.
Any other questions? Okay.
Thank you, Tammy, for the presentation. What's the incidence of conversion of blood surface to adenocarcinoma? Is there any data?
From paresophagus or from high-grade dysplasia?
Paresophagus.
No more. We make a study about this conversion from paresophagus to adenocarcinoma, even using proton pump inhibitor, and there is a debate in this situation. Some authors say in paresophagus using long-standing therapy of PPI will turn to the adenocarcinoma. Actually, there is no data. There is no data for this transformation from even paresophagus or high-grade dysplasia to the adenocarcinoma.
On the other hand, I think this is a very risky maneuver because most of our endoscopists fear of perforation because fragile wall of the esophagus.
Yeah.
How you can control this maneuver during the procedure?
Thanks. First,
a combination of the thickness of the wall of the esophagus and this here.
For the esophagus, lower esophagus. Firstly, I will thank you for this question. Actually, the segment of paresophagus will be in the abdominal esophagus, the lower 5 centimeters of the esophagus, which is the site of esophageal varices injection. I think it is phenolamine injection in esophageal varices. The needle is more hazardous than it. I think it is easy. Any endoscopist can use a needle for injection for phenolamine therapy. Will use this situation, but with expert.
Because he insisted that no one can do it unless it is expert in this, because it is a delicate maneuver.
Yeah, I think in this situation, not for injection and not for snaring. How to detect the flat small lesions? You must firstly do good insufflation, and then must cleaning the mucosa well by saline and sometimes acetylcysteine. Then we use another method like chromoendoscopy spray to detect the lesions to be biopsied. Then it's the same will be
this maneuver. I see a video of it. They inject the dye and the lesion appear in a change of color.
Yeah.
So they know that this is something in there.
Yeah, I totally agree.
Thank you, Dr. Danny.
Thanks.
Now we will move to the next presenter, Dr. Ahmed Mandi. He is a lecturer of the medical oncology in the NCI Cairo University.
Good afternoon, everybody. Thank you for having me. Good afternoon. Thank you for having me. And it's an honor to be among my professors and my teachers. Today I'll be talking about the predictive value of FATS, which is an abbreviation for fragile site associated to suppressor gene, and the expression on the sensitivity of cisplatin in advanced non-small cell lung cancer. So to start with, as we all know, lung cancer is still the leading cause of death in the US in both males and females. And it's the leading cause of death, not according to incidence. In Egypt, a beautiful paper by Dr. Amal Sami pointed out that lung cancer is the fourth after liver, bladder, and lymphoma, with the highest incidence in Upper Egypt. Non-small cell lung cancer comprises 87% of the incidence of lung cancer, and survival decreases with the advanced stage from 59 months to stage 1A to 4 months for stage 4. What about the FATS gene? The FATS gene is one of the genes for the family of chromosomal fragile sites, which are loci that are prone to gaps or breaks within metaphase chromosomes. They are observed in all humans, and they are a component of normal chromosome structures. P53, as we all know, P53 is the main tumor suppressor gene, and there is some theory that it's standard to be mutated in almost all cancers. So P53 malfunction pathway is almost a universal hallmark of human tumors. It controls multiple cellular